Today I'll be taking class on parasitic infection of the skin, soft tissue, musculoskeletal system, and the fungal infection. The parasitic infections which affects the skin, soft tissue, muscular system are different. These are the parasites which infect. But in this, only few of them we are studying, like protozoa infection, like cutaneous leishmaniasis, then trypanosoma chancre, and chagoma. Then in cestode infection, none of them we are studying. Trematode we are studying is cutaneous paragonemiasis and nematode infection. It is cutaneous filariasis, dracunculiasis, then trichinellosis, and cutaneous larva migrans will be studied. So now we come to leishmaniasis. The causative agent is leishmania. The infective form is promasticode form. The vector is the female sandfly. The scientific name of the sandfly is Phlebotomus sargenti. The habitat is common in humans. The amastigoid form resides in the reticular endothelial cells of the skin. So once the promastigoid form from the sandfly enters the body, it enters the skin macrophages and transfers into a amastigoid form, and it is the amastigoid form which we will view under the microscope. The diagnostic form is amastigoid form in the macrophage known as the Leishmania donovani bodies, as the LD body. This is the life cycle of the leishmaniasis. First, it is a sandfly, then it will bite the humans, and in the humans, the promastigoid converts to amastigoid form in the reticular endothelial cells, as the skin macrophages. And the amastigoid form multiply in the cells of various tissues and infect other organs. And again the sandfly takes the blood meal, ingests the macrophages infected with amastigoid form. And ingestion of parasites cells is the next cycle. Then amastigoid transfers into promastigoid stage in the gut of the sandfly, and it divide in the gut and migrate to the abscess. And again the sandfly bites. So the sexual reproduction takes place in the sandfly. So the definite host is the sandfly. This is how the leishmaniasis is. What different types of leishmaniasis caused? One is cutaneous leishmaniasis. That's it affects the skin, causing sores. The next is visceral leishmaniasis, as already I have told you in the visceral organs. In one of the classes where in liver, I guess, hepatobiliary system, I told about the visceral leishmaniasis. Then next is mucosal leishmaniasis. These are three main types of the leishmaniasis. So cutaneous, visceral, and the mucosal leishmaniasis, which affects the mucosal organs like larynx, and the respiratory tract. This is how the promastigoid form looks like. Just see this may be the image-based question like promastigoid. It has got a kinetoplast, has got a nucleus, and it has got a flagella. Whereas the amastigoid form has only the nucleus and the kinetoplast. There is no flagella, and it is circular in shape. Other one is cylindrical in shape. The next is cutaneous leishmaniasis. Is caused by Leishmania tropica complex. There are three species of Leishmania: Leishmania tropica, Leishmania ethiopica, and Leishmania major. With the sector is same, the female sandfly. What are the clinical features? The cutaneous leishmania is also called as oriental sore, and is called as Delhi boy, or is also called as Baghdad butter. These are the names which we commonly know actually. It occurs on the face and the hands. It begins as painless papule, then it becomes nodular lesion, then it ulcerates. The lesions heal spontaneously, leaving behind scar. Leishmaniasis recidivians is actually a granulomatous response producing new lesion. So it occurs years after the healing of the primary cells. So first there will be cutaneous leishmaniasis. It heals spontaneously. After some certain years, again there will be a granulomatous. There will be like a red color granulomatous lesion over the previous cutaneous leishmaniasis. That is called Leishmania recidivians. It is mainly due to the Leishmania tropica species leishmaniasis. It is characterized by scaly erythematous papules and nodules. That's why these lesions will look scaly. It will be erythematous as a glandular type. Granulomatous lesions are all are erythematous lesions. There will be papules and nodules also. The lab diagnosis is on microscopy. Amastigoid in the skin biopsy is seen, thin punch biopsy. Edge of the active lesion and touch preparations stained with Giemsa stain. So on skin biopsy, when you do a look at the microscope, we see the amastigoid form. Then culture, there is the NNN culture as a Noville, McNeil, and Nichols medium culture, and the Schneider Drosophila medium. These are two culture medium which are used for the isolation of the promastigoid form. And next is the Montenegro test. Montenegro test is actually a skin test. Here, delayed type of hypersensitivity to the parasite is seen. These are the investigations. We do microscopy, then culture media means NNN media, as a Novir, McNeil, and Nicole media, and Schneider's Drosophila media. And we do a Montenegro test. They might ask what is Montenegro test. It's a skin test. Type of hypersensitivity seen is delayed type of hypersensitivity to the parasite is seen. In the treatments includes local therapy. There's the pentavalent antimonal is the drug of choice. Whereas if systemic therapy is given, it is amphotericin B. Amphotericin B is mostly is used only for systemic therapy as the intravenous route. There is no oral agent for amphotericin B. Then other drugs we use is paromomycin, which for diffuse cutaneous leishmaniasis. Then we do is miltefosine we use. To prevent this leishmaniasis, we have to use insect control measures like insect repellents, then nest while sleeping, mosquito nest while sleeping. Then latter there is a prevention measures. This is how the cutaneous leishmaniasis look. Whereas in the you see the right side, there is granulomatous lesion. There is a leishmaniasis recidivis above, and it is occurring above the previous healed cutaneous leishmaniasis. As I said, it's called leishmaniasis recidivis. Next is Espendia, or is also called as mucocutaneous leishmaniasis. Mucocutaneous because it affects the mucocutaneous areas. The type of leishmania agent which causes mucocutaneous leishmaniasis is Leishmaniasis brasiliensis. It infects the mucous membrane of the nose, oral cavity, pharynx, or the larynx. All these are mucocutaneous areas. Ulcerative lesions are formed with erosion of the soft tissue, and it also erodes the cartilage. There will be loss of lips, soft part of the nose, and the soft palate because it will invade the soft areas like the tip of the nose and the soft pharynx. Then the lips all are soft area, and it will easily digest. Even it affects the cartilage also. So gradually, once the cartilages are infested and destroyed, if the nasal septum is destroyed, the nose will collapse and will lead to hypertrophy of the upper lips and nose. And this classically we tell the tapir nose. Tapir is an animal. You just Google and see later. Tapir is an animal, and its nose looks like it is nosed outside, and it is like hypertrophied. It is a flat nose. So it will look when the person is getting infected by Espendia or the mucocutaneous leishmaniasis, the patient's nose will look like a tapir nose. This is how the tapir nose look like. The mucocutaneous leishmaniasis, and when infected, you see the nasal bridge is lost. The nares are called, the soft tissues are all infected, and you can see lot of canals. So it's destroyed, and the nose also looks like a tapir nose. Cutaneous filariasis. Cutaneous filariasis is caused by nematodes, filaria nematodes, which resides in the skin and subcutaneous tissue. It includes loa. Then it includes other filariasis are Onchocerca volvulus and the Manzanella species. This actually is in this out of this, the important one is only loa. Then other they might ask you a 2-mark question, Onchocerca volvulus and Manzanella species. Rarely, it's just a side topics of the books. So loa is also called as African eye worm. Infection of the subcutaneous tissues and the eyes are seen. Is most commonly seen in West and the Central Africa. The life cycle is similar to Wicheria bancrofti. Vector is the female chrysops. These vectors of these animals, these filariasis, you just need to remember because there are different vectors for different filariasis. So the vector for loa is female chrysops, which is a fly actually, and most commonly it affects the soft tissues, the subcutaneous tissues, and the eye area it affects, and so that's why it's called as African eye worm. So when you remember African eye worm, it's seen most commonly in West and the Central Africa. What are the clinical features? As the Calabar swelling. Remember this Calabar swelling. What is Calabar swelling? It's also called as fugitive swelling. Most common form of liasis. It is subcutaneous swelling developing on the extremities like knee and the wrist. So Calabar swelling is also called as fugitive swelling. Most common form of liasis, and it is subcutaneous swelling. This affects the subcutaneous tissue. That's why it's called subcutaneous swelling developing on the extremities like knee or the wrist. Then other ocular manifestations seen are conjunctival granuloma, edema of the eyelids, and proptosis. So if it affects the eye, it will cause conjunctival granuloma. It will cause the edema of the eyelids. Once the edema of the eyelids is formed, it will cause the pushing of the eyeball outside. It will cause proptosis. What are the complications caused by lower law? It causes meningoencephalitis, it causes neuropathy, it causes cardiomyopathy. So it affects the CNS, so it causes meninges of the brain. It is called, therefore it causes meningoencephalitis, neuropathy, and it also causes cardiomyopathy. So since it affects the eye, it will enter the meninges of the brain, so it's called meningoencephalitis. And since meninges are affected, it causes neuropathy. Then cardiomyopathy is the one extra to that. So what is the treatment? Treatment, since it's the filariasis, the drug of choice for filariasis is diethylcarbamazine. Same here also. Along with that, you will give albendazole or ivermectin. Then sometimes you might need to surgically removal of the adult worm. So if the adult worm is removed from the eyes, so you might see if there is the adult worm roaming in the conjunctival area, then you have to remove it from the eyes. So you understood till now, right?
Yes, sir.
Okay, fine. Everything is straightforward, and no major questions are gonna come in these areas. I just took it because they might ask you like 2 mark questions. What they might ask you, what is Kalaba spelling, when it's found, or they might ask you features of leishmania, cutaneous leishmaniasis. They may ask leishmaniasis recidivans, but they won't ask you very high-fi questions on this. Everything straightforward questions. The next is Onchocerca volvulus. It causes river blindness. It's endemic in West Africa and South and Central America. The vector is Simulium, that is the black flies. Okay, so I told you different filariasis, different vectors. So the vector for lower lower is actually Chrysops. That's again a fly, female Chrysops. The vector for Onchocerca volvulus is Simulium, which is black flies. It's also a fly. The clinical features is skin, it will cause dermatitis, it causes intense pruritus and generalized papular rashes. The skin will look similar to like a leopard skin because there will be hypopigmented and hyperpigmented skin. Then next is soda. Soda means it is chronic hyperreactive form of dermatitis. So there'll be skin will show dermatitis will be there. So skin manifestation dermatitis will be there. There'll be intense pruritus and generalized papular rashes. That's dermatitis. Then you might find the skin looks like leopard skin because there'll be hypo or hyperpigmented skin type areas. Soda is chronic hyperreactive form of dermatitis. Whereas onchosarcoma is subcutaneous nodules that are firm, non-tender, containing the coiled adult worm. So what they might ask you, what is onchosarcoma? It's a found in Onchocerca volvulus disease and caused by Onchocerca volvulus. It is a subcutaneous nodule that are firm, non-tender, it's non-tender, and it contains coiled adult worm within it. Then ocular lesions are seen. There will be bilateral blindness. There will be conjunctivitis with photophobia will be there. You know what is photophobia is?
Yes, sir. The
Yeah,
light, when we look into the light.
yeah. When you can't clearly see the object or anything within the spot. Photophobia. The next is there will be keratitis. Keratitis is there will be corneal. There will be opacity. There will be inflammation of the cornea. It will lead to keratitis. The next is lymphadenopathy. Lymphadenopathy means the inguinal and the femoral lymph nodes are enlarged. So there will be lymphadenopathy. So in onchocerca volvulus, there will be skin manifestation, and skin manifestation will lead to onchocercoma, a subcutaneous nodules that are firm, non-tender, and contains the coiled adult worm. Then there will be ocular lesions. Ocular lesions will lead to bilateral blindness. There will be conjunctivitis and will lead to photophobia, and there will be keratitis. Then lymph node enlargement will be there. The inguinal and the femoral lymph nodes are most commonly involved. Then next is lab diagnosis. Microfilaria in the skin scrapings. Serological tests are done. Serological test in that molecular method is polymerase chain reaction. Then Mazzotti skin test is done. Treatment is ivermectin is the drug of choice for Onchocerca volvulus. This ivermectin is the drug of choice. Then next is Mansella species. It includes Manzanella spestens, then Manzanella ozadi, then Manzanella stratocera. All you just no need to know, learn all the species name. Sorry, the generic name. You just need to know Manzanella species and then mainly Manzanella spestens and ozadi. Nothing else you need to know. They will not only ask you the organism's name. Just Manzanella you just. So the transmission is by the trilcoids, that is the midgets. Adult worm resides in the scissors cavity, mesentery, and the perineal tissues. Then microfilaria circulates in the blood. Adult worm actually is the adult worm which lies in the serous cavity, mesentery, and the perirenal tissues. Then microfilaria circulates in the blood. So clinical features is non-pathogenic, but can cause, it is actually does not cause any, like you won't find any classic clinical features, but the features which we see is similar to like a hypersensitivity reaction. That is, it can cause angioedema, it can cause urticaria, pruritus, that's itching, and it can cause calabar like swelling. Fungi, that is acute periorbital inflammation will be there, and this acute periorbital inflammation will push the eyeball outside as a fungi. So treatment here is again dietase carbamazepine or you can give albendazole. You got it?
Yes, sir.
Yeah. So in this actually you just need to know just the names. You just need to transmission is by the Quilcoides midges, then adult worm resides in the serial. Okay. What I've given you just need to know. Nothing else more about this. Because this may be just a 1 mark question or 2 mark, or they might not even ask also this question. Since they was there in the book, I just thought few of this. Then this guinea worm is a common question because even though it was eradicated, some people likes asking this question. There's a dracunculiasis. It's also called as guinea worm disease or dracunculiasis. Causative agent is Dracunculus medinensis. It is seen in the sub-Saharan Africa. It is verge of eradication. This life cycle is there is two hosts. Definitive host is the man, and the intermediate host is the cyclops. The mode of transmission is drinking water from the stagnant pools containing the cyclops. Cyclops also is actually a, you can't see the actually the organism. It is also seen under the microscope. In the naked eye, you can't observe. So once you take the stagnant water and see under the microscope, you might find the cyclops organism. In man, the cyclops digested in the stomach, releasing the larva. So this is the life cycle how it is for guinea worm, dracunculiasis. Man acquires infection by consumption of water containing the infected cyclops, harboring the third stage of the larva. Cyclops are digested in the stomach, and the L3 larva is released. That is the third stage of the larva is released. Larva penetrates the small intestine. It migrates to the thoracic muscles. Molting there occurs. It forms the adult worm. Sexual maturation, then it forms a gravid female worm which migrates throughout the body. It first the third stage of larva penetrates the small intestine. Then after penetrating the small intestine, it travels through the thoracic muscle. So it is in the lungs which this adult worm develops, and it gives the sexual maturation. Gravid female worm migrates throughout the body. Then from in the body it just resides. It resides in the skin. So it enters the skin, then so it enters the body and what penetrates the small intestine. From the small intestine, it goes to the lungs. In the thoracic wall, it develops into adult worm and it migrates to the skin. And in the skin, it forms blister. Adult female worm discharges the L1, the first larva. First larva is from the blister. So when the person with the blister swims in the swimming pool, this larva enters the water, and this water is then the larva is taken up by the cyclops, and then again the cycle repeats. So first man occurs by drinking or swimming in the water. So when he swims in the water, stagnant water, he will drink the water. So once he drinks the water, the cyclops enters the small intestine. In the small intestine, it penetrates the intestinal wall, goes to the lungs. In the lungs, it matures into adult worm. Then female worm gives on female worm is formed. This pregnant female worm is enters moves from the lungs to the skin, and in the skin it forms blisters, and this blisters, the adult female worm will be sending out the first stage of the larva into the water when the person again swims in the water, and again the cycle repeats. So you understood, right? Hello, can you hear me?
Yes, sir. Yes, sir.
Yeah. So you understood the cycle?
Yes, sir. I understood.
Yeah. So if you find this cycle difficult, just make your own cycle like arrow mark with like what I told right now. Man ingested the cyclops. Cyclops enters the small intestine. Small intestine it penetrates into the small intestine. Then in lungs. From the lungs to the skin. So from the in the lungs it forms the adult worm and the pregnant female worm. From the female worm to the skin. Skin it releases form blisters. blisters, it releases the larva into the water. Again, the cycle repeats. That's a simple thing.
Yes,
Now
sir.
we come to the clinical features. Clinical features is painful blisters from which female worm emerges. Local, that's what I told you. The blisters are formed. From there, the female worm emerges and releases the larva. And once the female worm comes to the skin, there will be local erythema. There will be around the blisters. There will be fever. There will be pleuritis itching. Then most common sites are seen in lower legs, ankles, and feet. And once these blisters are formed, there might be secondary bacterial infections occurring on the blisters from the commensal bacteria. So commensal bacteria will infect the blisters and they leads to secondary bacterial infection. So this is how the dracunculosis blisters looks like. And the blisters, where you can see the adult female worm of dracunculosis is extracted from the blister. Treatment, the treatment is by worm removal. Symptomatic treatment is like if there is itching, you can give some ointment, or you can, if there is pleuritis, local erythema, you can give antihistamines and steroids. So this will help in controlling the symptomatic treatment. So next is trichinellosis. Trichinellosis is the causative agent is Trichinella spiralis. It's a common parasite of the pig. So if, the pig's flesh will have this parasite. The morphology is adult worm. There will be 4 stages of larva. There will be no egg stage here. Larva is the infective form which forms the cyst in the muscles. So I'll tell you, I'll explain you each and everything. What is this stage? What's the morphology? Because this very trichinellosis actually is very important because it causes encystation within the muscles, and you find the organism when you do the muscle biopsy. This is how the trichinella larva looks like on the right, and the left. What I told you, the trichinella cyst within the human muscle. So muscle will have the dead trichinella cyst within the muscle. So this is how the life cycle is. First host is the pig. Man is actually an accidental host and a dead end host. Mode of transmission is ingestion of raw or uncooked pork containing the encysted larva. That means the pig's muscle also will have this larva, and we humans or the carnivorous animals might eat this muscle with if it is infected with the larva. So mode of transmission intention of raw or uncooked pork. It's not actually cooked pork, it's the raw or uncooked pork containing the ancestor larva. Larva enters the duodenum and develops into adult worm within 2 days. Gravid female directly develops into larvae. There's no egg stage. Larva goes into muscles of the tongue, muscles of the mastication, then thigh muscles, and get encysted. Then few months it gets within after few months it gets calcified, and once it gets calcified it will die off. Then next is intestinal phase. Most are asymptomatic. Once the trichinella larva enters the stomach or the intestine, it's still asymptomatic. There won't be any symptoms. Even though if there is any symptoms, it will be if there is increased viral load or anything, it will be worse watery diarrhea, nothing else. Then next is larva migrans. It appears in the second week after the infection. Periorbital and facial edema will be there. Hemorrhage in the subconjunctiva, retina, and the nail beds. There will be macropapillar rashes, migration to heart, CNS, and the lungs are seen. So larva migrans, it may be visceral larva migrans, it may be cutaneous larva migrans, which appears this larva migrans is seen during the second week of the infection. When it travels to the eye, it will be a periorbital swelling and facial edema will be there. And it might lead to hemorrhage in the subconjunctival area, retina, and sometimes it may lead to hemorrhage in the nail beds. There may be maculopapular rashes, less like what dengue fever, also particular hemorrhages, maculopapular rashes will be there. Migration to the heart, that's a visceral larva migrants. It might migrate to the heart, or it might migrate to the CNS, or it might migrate to the lungs process. Then next is muscle encystment. 2 to 3 weeks after the infection, it is seen. There might be myositis with myalgia, that is inflammation of the muscles with there may be muscle pain. Myalgia is muscle pain. There might be musculoskeletal edema will be there, and there might be weakness. Extraocular muscles most commonly involved, followed by biceps. So they might ask. So the most common muscles involved in infection is the extraocular muscle, that's the eye muscles. That's why there will be periorbital edema, facial edema. And there might be orbital pain, like when the person moves the eyes to the left or right, there might be severe pain. So there will be muscular muscles are more common involved. Second most common involved muscle is the biceps, and muscles of the jaw, neck, lower back, and diaphragm are also involved. So first will be intestinal phase, and there won't be any severe symptoms. Then once there is larva migraines, then all the symptoms are appearing. Larva migraines is, it will be cutaneous larva migraines will be there. Then visceral larva migraines will be there. Cutaneous larva migraines will lead to skin infection, pruritus, and all those things. And visceral larva migraines will most commonly it will migrate to the muscles of the eye, as periorbital edema and facial edema is seen. Then next is hemorrhages in the conjunctiva. There will be retinal hemorrhages and nail hemorrhages are seen. And once hemorrhages is seen, you find maculopapular rashes. Then there might be visceral level migraines like migrate to the heart muscles, then CNS, like the brain and the lungs muscles. Most common muscles involved is the of the eye or extraocular muscles, followed by the biceps and the muscles of the jaw, neck, and the lower back and the diaphragm. What's the lab diagnosis? We lab diagnosis is done to demonstration of the larva. So muscle biopsy is done. Then serological diagnosis is ELISA, bentonite flocculation test, Western blot. You just need to know the names, nothing else. Then Batchman intradermal test is done, and as antigen used is the Batchman antigen, and X-ray is done to detect the calcified muscle cyst. So once the calcified muscle cyst is done, since it is calcified, you can view under the X-ray. So demonstration of the larvae is by the muscle biopsy. You can find encysted larvae, and encysted larvae are dead larvae, so no problem. Then serology we use is ELISA, bentonite flocculation test, Western blot. Batchman intradermal test as antigen uses Batchman antigen, and X-ray is done to detect the calcified muscle cyst. Treatment is thiabendazole and mebendazole. These are the next group of the albendazole group. Is the thiabendazole and the mebendazole. Then next is cutaneous larva migraines. Skin lesions produced by the nematodes of the lower animals when they accidentally infect the mans, then you will find the cutaneous larva migraines. In humans, the larvae accidentally infect the man, not able to complete their normal development. So cutaneous larva migraine usually occurs in infection with nematodes who usually have an accidental infestation in humans. So I remember in two class before I told you about the visceral larva migraines, right? You remember? Hello?
Yes, sir.
Yeah.
Ocular.
Yeah, you at time I told that why these larva migraines are happening. Okay, doesn't matter. If you don't remember, it doesn't matter. I'll tell you again. Actually, no, this larva migraines happen because actually they are the humans are the dead hand host. So they can't infect the humans. So and they can't do a sexual reproduction inside the human. So they don't know what infection to do cause. So they keep roaming within the human body, and they might go into the muscles, they might go into under the skin, or it might go into organs. And once it reaches the skin, it is called cutaneous larva migraines. And once it reaches the eye or the other muscles, it is called the visceral larva migraines. So you understood?
Yes, sir.
Yeah. So the life cycle is completely arrested. There is no, they don't have a life cycle. They'll be in the larva form and they'll die off there. So during their migration, they'll cause various hypersensitive reactions or other complications. So larva accidentally infects man, not able to complete their normal development. Life cycle get arrested, and larva wanders aimlessly in the skin and the subcutaneous tissue, causing the cutaneous larva migraines or the creeping eruptions. So clinical features includes ground itch, that is the pruritic maculopapular dermatitis, and rashes at the site of skin penetration. So it's called ground itch because it's at the site of the skin penetration of the larva. So it causes pruritic maculopapular dermatitis and rashes at the site of skin penetration. Then larva occurrence is pathognomic serpiginous article rash near the legs. So near the on the legs, right? Serpiginous means snake-like. So when you see the you'll find like a directed veins on the legs. So that is larva current. So pathognomic serpiginous articarial rash near the legs. On the legs, like how you saw the dracunculosis is there, right? So like that only you'll find serpiginous, like snake like the thickened vessels type near on the leg. You'll find that the layer type rashes on the leg. That is called larva currents. So what's the treatment for cutaneous larva migraines is Thiabenazole, again, what same treatment like before, thiabenazole is given. So parasitic infestation of the skin, you understood?
Yes, sir.